All right. Hello, everyone. Welcome to today's VMR. I'm so happy to be here today and to be co-discussing with no other than Kirtan. We have Kritika who is presenting a case today. Kritika, do you want to say hi and tell people how you're doing?
Hi everyone, I'm Kritika from Bangalore. Very happy to be presenting the case today.
Yeah, and so are we, Kritika. Like all the cases that I've heard from you were so interesting, and I can't wait to discuss your case today. Before I pass the mic to Kirtan, I really want to thank the people who are also making this possible today, who are Lyra and Magnus, who are going to be scribing today. Do you want to say hi and tell people what's up in your life right now?
Yeah, hi everyone. I'm Magnus. I'm from Denmark, and I'm scribing for the first time today. But I have Lyra on my side, so I'll be completely safe, I'm sure. And yeah, really looking forward to the case. Excited for the discussion.
Yeah, hi everyone. I'm Lyra. Yeah, I'm very excited for Magnus's first time scribing. I'm sure he will do great, and so very excited for the session today.
Yeah, thank you both so much, Magnus. I'm very sure that this is going to be awesome. And last but not least, thank you so much, Simi, for jumping in and doing the teaching points today. How are you doing today?
Hi, I'm doing great, and I'm very excited to capture the poetry today. We have Kirtan and Elena, which means a wonderful discussion. So looking forward to it.
Yeah, thank you so much, all of you. All right, Kirtan, now you. How is it going?
Perfect.
How is the new attending live? How is that treating you?
Yes. So thank you, Elena, for introducing everyone. Thanks to friends for scribing and teaching, and Kritika for presenting the case. And I also wanted to thank Noah for giving me the opportunity to discuss today, because initially he was scheduled, but unfortunately he couldn't make it. And this is, I think, the second time that I am having impromptu discussion with Elena. Last time it was Charmin with Elena, but Charmin can't make it, and I was the one. And then today also. So I have this thing with Elena. We have never discussed on a scheduled basis, is always impromptu basis. And last time when we did it, it was like, I remember amazing case of gonococcal endocarditis. So I'm sure that today also the case is going to be great, full of learning, full of the juice. So thank you so much to everyone who is joining the session today. And Kritika, whenever you are ready, we can get started.
Okay, shall I go ahead with the first aliquot? Yeah, so we had a 65-year-old male who presented with chief complaints of easy fatigability and loss of appetite for 3 months. Should I go ahead with HOPI? Or do you want to discuss? So history of present. Yeah, so the patient had easy fatigability from 3 months in the form of reduced capacity to do work. So the patient says he was a farmer by profession. So he's stopped going to the farm and prefers staying back at home. And complaints of decreased appetite from 3 months, reduced food intake. And patients also says that he has a sensation to defecate after each meal. So review of systems, patient has had no weight loss, no breathlessness, no dysphagia, any nausea, vomiting, fevers, loose stools, or any bleeding manifestations.
All right, is this a good place to stop, Kritika?
Yeah.
Okay, perfect. Yeah, thank you so much for the first aliquot. I love the chief complaint and the HPI. Very well presented. Yeah, I think there are like 3 main things I think that we can follow. So it's first of all, it's an elderly patient. We don't know any of the past medical history yet, but usually patients who are at the age of 65 may have some comorbidities that may or may not be related to this case today, but definitely something to keep in mind here. I think for a long time I had, and I still have, difficulty with fatigue because I always assumed that it's a very non-specific symptom. But I think the more I've been here and joined VMRs, the more I note that fatigue is not that non-specific at all. And I love how Kritika asked the patient what this might actually mean to the patient, because many times when patients report fatigue, they actually mean something else. And something to really worry about is shortness of breath. So usually when a patient reports fatigue to me, I really want to know if this fatigue is exertional or not exertional, which it doesn't seem to be the case here, that it's shortness of breath, but definitely something to keep in mind. And I think Kirtan can talk about this much better, but I think fatigue often leaves an imprint in the CBC. So what we might see in the CBC is electrolyte disturbances, is potentially inflammation. And there are some diseases that really have very prominent fatigue, and some of those are chronic pain diseases. Many autoimmune diseases have chronic fatigue. So I think that's definitely something to follow and see if it pans out here. And then we have this combination of loss of appetite and what seems to be some increased defecation, or at least defecation right after eating. So I think physiologically, when you eat something and the food enters your stomach, you get this kind of reflex. We prominently see that in kids, I think, that you tend to like defecate after eating. Sometimes you can even have postprandial pain, which doesn't necessarily have to localize to the biliary tree or to the stomach, but actually can be a feature of like colon disease, because this like reflex is triggered by eating here. I think I would be curious just to know if there has been any changes in stool. So if this was accompanied by some sort of like loose stools, some sort of diarrhea. And I think we can talk more about this if we know that we might potentially be dealing with a diarrheal illness here. And I think I'm not making too much more of the loss of appetite, because I think I would point that towards the easy defecation that the patient seems to have after eating. Yeah, I think I'm just going to stop here and see what thoughts Kirtan might have.
Perfect. Thank you so much for setting the background for me, Elena. I think you touched upon each and every aspects of it, and I agree with you from the beginning that although fatigue is a little bit non-specific, but it could be coming from, let's say, anemia and electrolyte disturbances, or it also might mean that there is a systemic process going on, and because of the associated cytokines, like we have discussed before, that those cytokines can affect multiple aspects of your body, right from your appetite centers in the brain all the way to your GI tract. For example, let's say if you have congestion in your GI tract from heart failure, often people with heart failure have anorexia just because whenever they eat something, they just don't feel right because their bowels are not doing well, right? So that can also contribute to the sense of fatigue. And similarly, sometimes people can have, let's say, obstructive sleep apnea, and which can contribute to fatigue. So there are so many individual diagnoses which can be linked to fatigue. So often we don't focus on fatigue initially. We try to figure out other differences and then link it with fatigue. Regarding the fact that this patient has sense of defecation after each meal, so I agree with you that it kind of makes us wonder if something is wrong with the colon. And there is this loosely defined term known as gastrocolic reflex. Basically, it means that whenever some food enters your stomach, it causes a reflex involving the vagus nerve. It goes all the way back to your brain and then comes back anterograde through the enteric nervous system and ends up stimulating the motility of your colon. And this can be seen even in physiologic states sometimes, that right after people eat, they have the sense to use the restroom. But what can be the pathologic counterpart of this? So pathologic counterpart could be that since this person is older and since this person has fatigue, and as Elena said, maybe we will see anemia on CBC. So is it possible that, let's say, this person has some kind of structural obstructive defect in the colon, which is impairing the motility of the food through it and the stools through it, and that's why right after eating you are getting defecation, right? Sometimes bowel ischemia, either in the form of arterial ischemia or in the form of venous congestion, can also dampen the structural functionality of bowel, and people can have this sense of defecation. And You can have inflammation in the colon as well, which can do this, but then it may not be related to eating each meal. And similarly, if we go proximally in the bowel, so people can have pancreatic dysfunction, people can have hepatobiliary disease, but they don't tend to cause defecation right after you eat the food. That is more of kind of delayed diarrhea once you have consumed the food and you can't digest it. So these are like the rough outline of how we approach it. But again, sometimes we have to understand that these symptoms may be just a red herring, right? So again, we have to go to the bedside and ask the patient that, is this something which is very consistent and so significant that it is affecting your daily life? If I go to the bedside and patient tells me that, yeah, you know what, doc, I sometimes have to use the restroom after eating meal, and it happens once or twice in a week, then I'm not going to focus too much of my energy on it. But if patient says that, yeah, this happens like 3 times in a day, breakfast, lunch, dinner, I have to defecate, then I will employ more my energy in figuring out that what could be wrong with the bowel. So I think next steps, like if we get the past medical history to see what comorbidities patient has, what medications they have been taking, that can guide us in moving ahead. So Elena, I think you did the good framework and I was able to relate to it. So thank you. And maybe we can move to the next aliquot.
So going to the past medical history, the patient has no known comorbidities. Patient was admitted with similar complaints 2 months before in an outside hospital. The patient was not aware of the admission details and what was done, but all they could tell was the patient received 1 unit of PRBC. They refused for any further evaluation and got discharged against medical advice. Coming to the past medications, patient is not on any medications and no significant family history. Social history, patient has a history of tobacco chewing for the last 10 years. Apart from that, patient has no other substance use or no allergies. So that would be aliquot 2.
Yeah, awesome. Thank you so much.
Yeah.
Do you want to go first?
Yeah, no, Elena, I was just maybe thinking that, Kritika, do you have some clinic physical examination findings? Maybe we can involve that as well.
So I'll go to aliquot 3 then.
Yes, yeah, that's fine. Yeah.
Okay, so coming to the vitals, the patient had a BP of 120/80 and pulse rate of 88 beats per minute. On general physical examination, patient had pallor and bilateral pitting edema till the knee. And systemic examination wise, cardiovascular, patient had a soft systolic murmur in the pulmonary area. Other systems were normal.
Yeah, awesome. Thank you so much, Kritika. Really, really interesting aliquot. And I think it's usually interesting to like go back to some of the things that we have said in the aliquot before and see if they sort of pinned out here. So we've been talking about fatigue, and I think we might have a decent explanation for why the patient might be fatigued at this point. And I think we actually have 2 clues here. So we learned from Kritika that during the last admission, the patient has received 1 unit of RBCs. So the patient was found to be anemic, and we can even see that on exam now. So the patient has pallor. And I think I'm gonna go through the other things first before I go through the anemia pattern here. So before even jumping in, I think it's really interesting, especially with the loss of appetite and this like defecation after a meal. I didn't mention this before, but it seems like it's not only discomfort, but has led to dysfunction, although the weight still seems to be sort of normal here. So let me see. I think what also struck me was the tobacco use of the patient here, which definitely means that the patient has an increased cardiovascular risk factors for atherosclerosis, something like mesenteric ischemia, things like that here. And tobacco itself can affect bowel movements and can lead to increased bowel movements and things like that. But also increases the risk for many malignancies, including colorectal cancer. What's interesting is that, so we are assuming that the patient is anemic, potentially from a GI blood loss here, but it seems just based on the vitals that we see, we have a normal blood pressure, we have a normal heart rate, that the patient is in like a compensated state here. So this has happened probably over weeks or even months, which doesn't point us into like an acute GI blood loss here. I think what's interesting too is the systolic murmur in the pulmonary area. And what we know from the patient so far is, yes, they don't seem to have any comorbidities, but it's that we no comorbidities that we know of. It seems like the patient may not have too good access to the healthcare system, or might have had bad experiences here, because it seems like the patient has like left the hospital during the last hospitalization. So we might not actually know how regularly the patient sees their PCP here. Yeah, and I think with that, we can talk a little bit about the anemia and where it might be coming from. So base rate, the most important things for anemia, especially in elderly patients, is really blood loss. Especially from commonly from the GI tract. We can sometimes see that from the GU tract. Patients can also bleed into their lungs. They can bleed into their skin, or like big compartments like the retroperitoneum. They can bleed into the abdomen. But it seems like many things are really pointing towards the GI tract here. So I think that's something that I would consider and think about more. I don't know what to do yet of the bilateral pitting edema that we can see here. It doesn't seem like the patient is taking any medications that could do that. Patient might have potentially heart disease. I think I would definitely get an echo for this patient, especially in the context of the murmur, although the murmur could potentially be like a functional murmur in the context of the anemia. But definitely curious if the patient has been experiencing any orthopnea, if the patient has, if the edema is new to the patient, things like that. A little bit disorganized, but I'm sure, Kirtan, you can organize them better.
No, friend, you did amazing. Like you were able to delineate the individual differentials and the pathway for each of the problems. And I agree with you that whenever you are dealing with a problem which is very common, like let's say pitting edema, it is completely possible that the cause of pitting edema is unrelated to maybe anemia or maybe the murmur. And it is also possible that they are related through a very common diagnosis. So in either scenarios, rather than hunting for a common diagnosis which can explain all of this together, we should do the individual workup. So for anemia, like let's say given this person is very old, and of course you will do the MCV, iron studies, nutritional studies, but anemia in somebody who is above the age of 50, without a doubt, patient needs colonoscopy, right? At some point in time. And as you said, that this person has the symptoms which are localized on the GI tract, this defecation right after eating meal. He definitely needs inpatient workup to make sure we are not missing an life-threatening cause that who knows patient goes home this time and suddenly bleeds 1 liter of blood and then we can't save the patient, right? So this is that kind of scenario where you can get the labs, but you have to do the steps, which is what you delineated, that we need the colonoscopy to make sure nothing is in the GI tract contributing to anemia. Now coming to the murmur, so Kritika told us that this was in the pulmonary area. Now, of course, cardiac examination is very skillful examination, and oftentimes even the most skilled cardiologists may not be able to interpret the murmur at the appropriate position. So if it is in the pulmonary area for sure, then it might make you wonder, is it coming from pulmonary valve? Like maybe there is pulmonary stenosis, some degree of pulmonary hypertension, or maybe the murmur is actually coming from the aortic region, but you are just hearing it in the wrong way based on the inter-observer variability. So anyways, we need echo for the pitting edema, and that will show us if there is any issue with the aortic valve, pulmonary valve, or pulmonary hypertension. And now coming to the pitting edema part. So S is the standard workup for pitting edema, that we will see if it is coming from heart. We will evaluate for any signs and symptoms of pulmonary hypertension. So we can see if there is any evidence of ascites, if on ultrasound of abdomen, if we are seeing any evidence of cirrhosis or not. And we will get the albumin as part of our labs. And we can get the urine studies to make sure that we are not leaking it in the urine. If all of this turn out to be fine, then we can say that maybe this person is losing albumin either in the GI tract, or patient is just malnourished or cachectic from the underlying inflammatory neoplastic state, which is why the albumin is low and you have pitting edema. So we need a structured approach, and if we cannot find answer through any of this, then maybe we can think about even rarer possibilities like could it be lymphatic dysfunction or not, right? And so this is the pathway which we can take, like individual workup. And if we just have to think about something which can unify all of this, it's hard to say, but we can say that maybe somebody had a tobacco use disorder, had atherosclerosis, had atherosclerotic disease causing ischemic cardiomyopathy like heart failure, which ended up causing pulmonary hypertension, which ended up causing retrograde congestion, and had caused pitting edema and bowel congestion causing all these symptoms. So this is kind of like a simple diagnosis which can present in this way. And then of course there are rarer and rarer possibilities that maybe there is some degree of aortic stenosis, and maybe you have colonic angiodysplasia, and both of them together kind of like, we know von Willebrand factor dysfunction, Hedy syndrome, and you get the bleeding. You can have, let's say, pulmonary valve dysfunction or tricuspid dysfunction, and you have right-sided heart failure, and you are having diarrhea, so maybe like carcinoid syndrome and things like that. But as I said earlier, that this is just for the kind of academic discussion standpoint. But in real life, the standard workup should pursue, as Elena said, that you pursue all of these individual puzzles individually because they are like very common, and then you may end up finding a unifying cause or maybe not. So excited to see that what did the labs show and if any basic imaging was performed.
Thank you for the discussion, Elena and Kirtan. So next aliquot will be the labs. So CBC showed a hemoglobin of 7.3, a WBC count of 3,390, platelet of 83,000, RBC count of 2.02 lakh, and hematocrit of 22.6, MCV of 111.8, MCH of 35, MCHC 31.4, a reticulocyte count of 2.3%. The corrected reticulocyte percentage was 1.16, and the reticulocyte production index was 0.6. The peripheral smear showed mild anisocoagulocitosis, predominantly macrocytes and macroovelocytes, with a good number of normocytic normochromic cells and few teardrop cells. The WBCs were normal in number, morphology, and distribution, with few hypersegmented neutrophils. Platelets were adequate, and vitamin B12 was normal. It was more than 2000 picograms per milliliter. Iron profile was within non-normal limits. Coming to the chemistry, sodium was 140, potassium was 4.2, albumin was 3.4, ALP 62, total bilirubin 0.6, direct bilirubin 0.3, indirect bilirubin 0.3, SGOT 16, SGPT 29, urea 22, creatinine 1.4, uric acid 6.8, LDH was 222, which was normal, calcium was 9, and glucose was 113. The urine analysis showed a urine albumin of 1+. The serology was not reactive, and ultrasound abdomen and pelvis was normal with no significant abnormality. That will be the end of aliquot 3.
Yeah, thanks so much, Kritika, for lining that out. Very interesting fourth aliquot. Let's go through the labs one by one. So I hope I caught everything here. I think the first thing that jumps out in the CBC is that the patient has anemia to the degree of 7.3 of a hemoglobin, which is low. And we not only see anemia, but we also see thrombocytopenia. And I think whenever I see a cytopenia, I ask myself, is the cell line being destructed peripherally, or is there a problem with production? And the more cell lines that are down, and I'm not sure about the WBC, maybe it's a little bit low as well. the more cell lines that are down, the more likely the bone marrow is the culprit here. But there are, I think, a few things that should be considered, especially patients who have a large spleen might have a peripheral destruction of multiple cell lines, even sometimes to the degree of pancytopenia. We also have to think, especially in the combination of anemia and thrombocytopenia, about MAHAs. And I think we don't have the haptoglobin yet, but the fact that the LDH seems to be normal, and I think AST was normal as well, makes this a little bit less likely. We also don't have any, like hemodynamic features of the patient like peripherally destructing acutely here. And I think another interesting aspect is that the patient seems to have a high MCV, which could potentially support even more that this might be going on, that the process might be actually inside the bone marrow, because the differential for macrocytic anemia really is substrates, namely folate and B12. I'm not sure. I think they were normal here, if I'm not mistaken. And then reticulocytosis itself can cause an elevated MCV, however, only to a certain degree. And I think whenever an MCV is higher than 105, I would think that something else is going on. I'm not sure if the retics are low, but I think they are. And this is another thing that would support our hypothesis that the patient might actually have something going on in the bone marrow here. Something to always consider next to substrates is really MDS in older patients. Yeah, so I think those are my thoughts on the CBC. For the smear, I'm reassured that we don't seem to have any schistocytes, which is reassuring. Anisocytosis is really a typical feature of iron deficiency anemia. The teardrop cells I usually think of, and I think Reza taught us this, the bone marrow crying. So something that is inside the bone marrow, like pushing it out. So something potentially like infiltrating the bone marrow. And the hypersegmented neutrophils, again, I typically associate with vitamin B12 deficiency. Let me screen the whiteboard. I'm not sure if we got that values. No, I think not, but that's definitely something that I would like evaluate for. And I think it's very important. I think the patient has been out of care, but usually what I do if I see a high MCV, I really want to go back because there might be multiple things going on. We have talked about this in this patient before. Just because the patient has a high MCV doesn't mean that they can't have iron deficiency anemia, which is still the most common cause. So it's important that we still get those values. And typically we can diagnose iron deficiency anemia with a low ferritin. This might, however, be elevated in the context of inflammation. So we still need to get like TSAT and other iron studies to confirm. I'm not sure about these values, and I'm definitely going to need Kirtan's help here. Yeah, and then I think, yeah, and the creatinine is definitely elevated. I think whenever we have an elevated creatinine, we want to know if it's new, what's the patient's baseline. The patient might have been out of care, so potentially hypertension, diabetes might be contributing here to potentially like an AKI or maybe even like a CKD kind of picture. We can evaluate that more with ultrasound of the kidneys, with getting potentially a PTH here, also like screening at the calcium and phosphate. Yeah, and I think the albumin that is positive in the urine, we definitely need to quantify to see how much it is. Could definitely point towards like glomerular pathology or just a component of CKD here. I'm not getting like I'm a little bit, because of all the things that we have talked in the last aliquots, I'm not sure what to make of the GI symptoms as of now, because with this aliquot, I'm really drawn to actually the bone marrow here. Yeah, curious to see what you're thinking, Kirtan.
No, I agree with you, Elena, that the tension is real, that we have so many labs and we are trying to interpret them. But then we are also looking at the bigger picture, that why did this patient came, right? The patient came with like easy fatigability, and maybe that can be directly related to anemia. But then we found this murmur on examination, we found the pitting edema, which we cannot directly link to the pancytopenia which we are seeing. So again, as we discussed in prior record, that we still need individualized workup for those problems, so that we don't anchor it just on the hematologic picture and we forget the side of the big things which are going on, right? So anemia in an older person, we still need to make sure that nothing is wrong with your bowel. So at one point in time, this person will definitely need colonoscopy, right? So Elena, that kind of links back to what you were emphasizing in the first record, that you are concerned about the GI pathology. And I am also still not drawn away completely from it. It's just that now I have additional problem to solve, which is hematology, but GI problem is still there. And similarly, like if we talk about the pitting edema, from the information which we got, we still don't have a picture of something which screams that, okay, albumin is 1, then you have pitting edema, right? Our patient has severe pitting edema and we still don't know the cause of it, right? So we will still need echo to make sure that your heart is not at the play. At least doesn't look like there is overt cirrhosis on examination. And Kritika can tell us the protein quantification, but since albumin is like 3.4, like it's definitely not nephrotic syndrome, because in order to have nephrotic syndrome, you need proteinuria and albumin below like certain cutoff. Sometimes it's 2.5 to 3. So it kind of makes us wonder that, and I think Rabi has told us this before, that when you have pitting edema, which is out of proportion to the classic things which we think about. So let's say if we get the echo in this person and we don't find the evidence of heart failure, then what can cause this? So things are pulmonary hypertension, then any localized venous obstruction in the retroperitoneum, which could block your inferior vena cava and can cause edema in the lower extremities. So that's why getting echo is important, because echo can also tell us if there is some degree of pulmonary hypertension going on. And then down the line, we can think about getting further imaging if we can't explain the edema of abdomen, right? Now, coming to the bone marrow, so I agree with you, Alina, that whenever you see pancytopenia with retic count, which is inappropriate, we know that your bone marrow is not able to function. And given the fact that we have prominent macroovelocytes, and although B12 levels are normal, but since we know that levels of vitamin B12, the way we measure it in assay, are dependent on so many things, and they can be either false positive or false negative from so many things. So the general dictum is that if you have really high suspicion, like let's say if this patient had no ovelocytes, no hypersegmented neutrophils, MCV was like 90, B12 levels are normal, then I won't pull the trigger to get methylmalonic acid levels. But in somebody like us who has MCV, which is clearly elevated, you clearly have hypersegmented neutrophils, then I would assume that let me go ahead and also get methylmalonic acid levels, just to make sure that I am not missing a very common cause, which is B12 deficiency. So B12 levels, you have to interpret it in context. So I guess in this case, we should get MMA, we should also get folate levels. And for the sake of completeness, like other nutritional deficits like copper deficiency can also contribute to macrocytosis. So getting all those three things would be important. And the reason why it is important in our case more so is because we were suspecting that maybe something is wrong with the GI tract, maybe some degree of malabsorption, or you are losing it. So it makes sense to get it. But if we move beyond it, then the most common, and HIV is negative, which is very important. So once you rule out the HIV as a cause of cytopenia, then the next stuff for macrocytosis is just stem cell failure, right? So things like myelodysplastic syndrome, aplastic anemia, PNH, and then something which is infiltrating your bone marrow. And the reason why I liked that hypothesis which you put, Elena, is because since we were thinking that could this patient have malignancy? Patient has a risk factor, like patient is a smoker, patient has fatigue, anemia, right? So is it possible that whatever solid tumor that this gentleman has, it could be lung cancer, it could be colorectal cancer, has it infiltrated your bone marrow itself? And that is why when it infiltrates, the word which we use for peripheral smear is like leukoerythroblastosis. Basically, it means that you are seeing the immature white blood cells and red blood cells in the peripheral smear as they are pushed out, right? So that is a strong hypothesis, and I agree with you that once nutritional labs are negative, that would be the top considerations, and this patient would definitely need bone marrow examination. Regarding the creatinine, Well, how to say, it's kind of like, we would say it's least of our concerns at this time because there are so many other things going on. We could, of course, try to give fluids to this patient little bit to see if it improves. We can get ultrasound of the kidneys to see if there is any obstruction. And we will see if the urine sediment showed anything in particular. But we can try to focus more on like the edema aspect and the bone marrow aspect, and then maybe we can figure out the kidney part. So anything else that you would like to get in the next aliquot, Elena? Any labs you are thinking?
I think yeah, thank you so much for breaking that down for all of us. I would be curious to know from you if the normal or like only like mildly elevated LDH does anything for you, particularly when thinking about vitamin B12 deficiency. Because I usually associate vitamin B12 deficiency, which causes like that degree of pancytopenia with a pretty high LDH, but maybe I'm wrong here.
So no, Elena, you're right that there is that association that when people have severe B12 deficiency, they can have kind of ineffective erythropoiesis in their bone marrow. And since you are killing the bone marrow precursors like pro-normoblasts and pro-erythrocytes, which have very high content of LDH in them, often LDH goes high, but the literature kind of suggests that most of the cases of B12 deficiency with high LDH comes from people who have pernicious anemia. And the reason is not very clear as to why only pernicious anemia causes high LDH and why not just B12 deficiency from something else, like let's say malabsorption. It's hard to say. But given the fact that you pointed it out, that's why we want methylmalonic acid levels, that even though LDH is not that crazy high, that doesn't lower my suspicion to pursue the next testing for B12 deficiency. So we should still get it. And of course, haptoglobin also to, kind of cement our hypothesis that is there hemolysis at all or no hemolysis. So haptoglobin will also help us. Yeah. And I also wanted to highlight the things which people have mentioned in the chat, like very good thoughts. Like I think, let me just see, so Sarah mentioned good thoughts, Lira mentioned it, that they were raising the question that could we have possibility of endocarditis going on, given that there is some bowel dysfunction, bowel malignancies, and then there is murmur. So thank you friends for sharing their thoughts in the chat. I agree that it's a good thought that we need to have it. That's why once we get the echo, we will get a better idea as to which valve is involved. And if appropriate valve is involved, then this hypothesis of endocarditis coming from colonic malignancy is definitely worth pursuing. So yeah, thank you for mentioning that. And Kritika, excited for the next aliquot?
Thank you for the discussion. So this will be the last aliquot. Actually, the patient wanted to, not get evaluated even this time around. So though we wanted to get an array of investigations, we couldn't get all of them. And we had to persuade the attender to get a bone marrow. So the bone marrow aspiration showed a hypercellular marrow, suppressed erythropoiesis, myelopoiesis, and megakaryopoiesis, increased lymphopoiesis with increased plasma cells of 20%, binucleate form and plasmablasts, atypical neoplastic cells of 55%, binucleated, trinucleated, and multinucleated, with a high nucleocytoplasmic ratio, open chromatin, large nucleus, prominent single nucleoli, and abundant cytoplasm. Bone marrow biopsy showed 5 to 6 bony trabeculae with marked hypercellularity, and the marrow was packed predominantly with sheets of blast cells or atypical neoplastic cells with large pleomorphic nucleus. Multinucleation was noted. So the differentials were query myeloma or a leukemia lymphoma process. The serum protein electrophoresis showed a gamma M spike of 0.15 milligram per deciliter, and the immune electrophoresis showed a lambda band and M band. So the impression was lambda free light chain associated disorder. The blood for free lambda light chain showed 7193.29 milligram per liter. So the diagnosis was multiple myeloma.
Yeah, very interesting, Kritika. Yeah, maybe before I comment on the diagnosis, I think when I heard what's going on in the bone marrow, I'm not like very like an expert here, but I think what really like stood out is that there's a lot going on in the bone marrow in comparison to the periphery, right? So there's like really cytopenias in the periphery, but there's like a hypercellular bone marrow that is dysplastic. So I think at that point, the question really was like, what is infiltrating that bone marrow? And I think the appropriate things that could be causing this is, as we have mentioned, myelodysplastic syndrome. I'm not sure how we actually do make that diagnosis. It's probably based on some like markers on the cell membrane. So maybe we can get that through like fax. But we have heard from Kritika that it seems like there are a lot of plasma cells that could potentially like produce immunoglobulins or like free light chains that are abnormal, so paraproteins. That the patient like went for all the workup for multiple myeloma was definitely the appropriate step here. Yeah, I haven't seen multiple myeloma too often cause such a severe bone marrow infiltration for it to present as pancytopenia. I usually you know, like the mnemonic that we learned in med school, I usually associate those symptoms more with like early stage multiple myeloma and not so much like bone marrow infiltration to that degree. But I'm definitely curious to learn from Kirtan and Kritika what they think about this case.
I agree with you, Elena, that in general, multiple myeloma doesn't tend to cause pancytopenia, and it is something which is not seen in at least the classic forms of myeloma. There are certain subsets of myeloma which have a poor prognosis. So it is also known as something like anaplastic myeloma. Some people call it as like plasmablastic myeloma. So it's that form of myeloma in which you tend to see so many blastic forms of plasma cells, and you can't just say that somebody has this rare form of myeloma based on morphology. You also need cytogenetic studies. So there are certain characteristic translocations which this kind of myeloma has. And that myeloma tends to behave aggressively in terms of it can cause more lytic bone lesions, it can cause more profound bone marrow suppression. So it is conceivable that if, like, let's say, maybe hematology did more stuff down the line, I'm sure once patient agrees, and they will plan the treatment based on the cytogenetic studies, and it is possible that this person can have this anaplastic or plasmablastic myeloma, which is why it was so severe. And regarding the point of creatinine being high, so like, can you attribute that high creatinine to myeloma? I mean, we know that myeloma can definitely affect the kidneys in so many ways. It can, but again, we kind of need like serial creatinine levels to make sure, because it is also possible that maybe this creatinine is coming from something else, like maybe pre-renal injury or something like that. So once the myeloma improves, the creatinine, if it improves also, then maybe you can say that it was from myeloma. And regarding the edema of the lower extremities part, so that part again is still something which we haven't answered completely. And again, maybe one of the reasons could be that we are not able to keep and convince the patient in the hospital enough to do all the studies. But another possibility to think about is that if this person has such an aggressive form of myeloma, then can they have some degree of amyloidosis, which ended up causing involvement of your heart, and maybe that's why you have pitting edema. So that's why getting an echo would have helped. Like if we see like very thickness of the walls of the ventricles, if we see some conduction deficits on EKG, all those indirect clues of infiltrative cardiomyopathy. So I think that could have helped us. And the defecation part, like patient has sensation to defecate right after the meal, we are still not sure. Like as we said in the first aliquot, that sometimes you have to establish that how significant that is, if it is impacting patient's life or not, if this person really has diarrhea or just the sensation of urgency, right? So those are the parts kind of, to complete the puzzle. I wanted to just touch base upon them, that what could be going on. But apart from that, Elena, your like approach was like spot on, that like reticulocyte counts are not appropriate. You were leaning towards the bone marrow, and we got the answer by getting the bone marrow. So like that's the good thing. And now maybe before we wrap up the things, maybe let me get back to Elena. Then any other final thoughts, Elena? Any like in terms of presentation, in terms of labs, anything which you need clarification for?
Yeah, thank you so much, Kirtan, for laying that out and sharing your experiences and experience with multiple myeloma cases. Yeah, I was actually a little bit surprised for this kind of presentation here. Yeah, I just hope that the patient is doing well and decides to, or like not decides, whatever works best for the patient to do the appropriate treatment here. Yeah, definitely gonna read some more about the form of multiple myeloma anaplastic that you have been talking about. I haven't heard that before. And curious to learn from Kritika what she learned from the case and what her thoughts are on this.
So yeah, like everyone had questions about the case, I did too. Actually, the bone marrow and the electrophoresis was done at an outside center. It was not done in my center. So I had to follow up the patient because they didn't want to get evaluated here. So I had questions regarding the other atypical neoplastic cells that they have made a mention of. And also the patient didn't have any osteolytic lesions. And also we initially thought of myelodysplastic syndrome because the patient had pancytopenia, but then there was no organomegaly or anything, and no atypical cells in the peripheral smear. So it was quite confusing for us as well. So now the patient is currently on bortezomib, and he's received 3 cycles of chemotherapy and he's doing pretty well.
Perfect. Thank you so much, Kritika, for telling us. And I agree with you that it's a little bit atypical, like these neoplastic cells, that are those neoplastic cells of hematologic lineage or some other kind of neoplastic cells. But since you told us that patient is taking bortezomib, like, I'm kind of taking a leap of faith and hoping that the patient received the correct diagnosis, and it must have been all these myeloma cells. And sometimes, as we said, that if this is really this form of myeloma, which is like very aggressive anaplastic, then you can have those atypical neoplastic cells with like 3 lobes of nucleus, tumor cytoplasm. And I'm sure that those doctors at that other hospital must have done due diligence to make sure that these atypical neoplastic cells are not coming from some other source, like some solid tumors. And maybe that's why they are moving with the bortezomib, which is the plasma cell directed therapy. So I think, yeah, good learning case, Kritika. Thank you so much for sharing. Just like Elena, I am also going to go and refine my understanding of like how myeloma presents and what are the different subtypes of myeloma. And thanks to Magnus and Lira for scribing. I mean, it was probably the first time for Magnus to scribe, but everything is very well organized. Like we didn't miss any data. So thank you so much for the hard work, Magnus. And now maybe I can pass the mic to Simi for teaching points.
Thank you, Kritika, for sharing such an interesting case. And thank you, Lira and Magnus, for describing. And I really love the discussion, Elena and Kirtan. And after such wonderful teaching, I have nothing to add. So I'll just give a very brief summary. So we started our approach with a patient who had fatigue and loss of appetite. And we were thinking that fatigue can be non-specific, but usually it has a systemic marker in form of anemia or electrolyte abnormalities or elevated inflammatory markers. And then the patient had anemia, murmur, as well as spitting edema. And we were thinking that whether these are related or unrelated to the unrelated processes affecting separately or in a syndrome that combines them all. And then we had pancytopenia and elevated creatinine. And as for the pancytopenia, we were thinking that either it can be due to peripheral destruction or due to a bone marrow issue. And whenever we have anemia and thrombocytopenia, we should also be concerned about MAHA. So that was something we were also considering here. And as for the elevated creatinine, we were thinking whether it is due to a bone marrow infiltrated process affecting the kidneys as well, or separately due to a lack of proper intake in this patient. And then the bone marrow biopsy results and electrophoresis confirmed multiple myeloma. And we discussed that this is this unique type of multiple myeloma called anaplastic myeloma, which can present with pancytopenia and has a more aggressive picture, and can also explain the cardiac involvement. Echo would have been helpful here. And I loved the case and the discussion. Got to learn a lot. Thank you so much.
Yeah, thank you so much, Simi, for jumping in and doing teaching points. Really outstanding and very well organized. Thank you all so much for being here today. And thank you again, Kritika, for presenting the case. It was a pleasure to discuss with you, Kirtan. I learned a lot. I hope you all have a great rest of your day. Bye.